Imagine spending, thousands of dollars to inject a regenerative miracle into your body. You're relying on the absolute cutting edge of modern medicine to rebuild your damaged connective tissue.
Right. I mean, you are expecting a total biological reset.
Exactly. But instead, you find out that a common everyday pill you've been taking for your joints or maybe your skin is quietly acting like microscopic scissors. And it's just shredding your new tissue just as fast as it's being built.
It really sounds like a medical horror story, doesn't it? But it is a biological reality that we see playing out in clinics all the time.
Wow.
We tend to view our bodies as these isolated compartments, right? Like one treatment handles one problem and another handles something completely different. We totally forget that the human body is a highly sensitive, interconnected ecosystem.
And when you start mixing different types of powerful therapies, that ecosystem it can descend into total chaos. The math just doesn't add up the way you think it will.
It becomes incredibly complex. I mean, sometimes the very medications we rely on to protect us from one disease can actively sabotage the therapies we use to heal from another.
Which brings us directly to the mission of today's deep dive. We know you love getting into the weeds of complex topics, and today we are focusing on a truly fascinating intersection of regenerative medicine and pharmacology.
Oh, it's a huge topic.
Yeah. We are going to unpack exactly how long-term systemic corticosteroid therapy alters connective tissue remodeling following intimate PRP injections.
We are looking at a classic clash of two medical titans here. On one side, you have platelet-rich plasma, or PRP, which has become the driving force behind regenerative treatments for connective and vascular tissue.
Right. And on the other side, we have corticosteroids, which are, let's face it, the gold standard for fighting inflammation.
Absolutely.
Like if you have an autoimmune flare-up, asthma, or a severe skin condition, steroids are often the hero of the story. But as our stack of research today highlights, they possess a very dark side when it comes to the long-term structural integrity of your tissue.
They really do.
So, okay, let's unpack this, because before we can fully grasp how steroids ruin the remodeling process, we need to establish what intimate PRP is actually trying to achieve at the cellular level. When those platelets enter the tissue, what is the underlying biological goal?
The ultimate goal is complete tissue remodeling and vascular regeneration. To understand how it achieves that, you kind of have to look at the process.
Okay, lay it out for us.
Well, PRP relies on taking a sample of your own blood, spinning it down in a centrifuge, and isolating the platelets. We normally think of platelets as just the things that stop us from bleeding when we get a paper cut.
Right, they form the scab.
Exactly. But in regenerative medicine, they serve a much larger purpose. When they're activated within the tissue, these platelets act like microscopic cargo ships, and they release a massive payload of endogenous growth factors directly into the surrounding environment.
And our sources list a whole alphabet soup of growth factors here. There's PDGF, BAG-OBB, TGF-beta-1, VEGF, and EGF.
A lot of acronyms, yeah.
It is. For those of us who aren't, reading molecular biology textbooks on the weekend, what do these individual signals actually do? I want to understand what the cargo is.
Yeah, let's break down the cargo. So PDGF-BB is platelet-derived growth factor. Think of this as the site foreman.
The foreman, okay.
Right. It calls stem cells and fibroblasts into the area and tells them, hey, it is time to get to work. Then you have VEGF, which is vascular endothelial growth factor.
And what's that one doing?
This one is entirely focused on plumbing. It stimulates angiogenesis, which is basically forcing the tissue to build brand new blood vessels to improve blood flow.
Okay, so the foreman arrives and then the plumber lays down new pipes.
Precisely. Next is EGF, epidermal growth factor, which forces the epithelial cells to divide and basically thicken the skin or the mucosal lining.
Got it.
And finally, you have TGF-beta-1, transforming growth factor beta-1. This is the master architect for the extracellular matrix. It tells your local fibroblasts to start churning out huge amounts of fresh, healthy collagen to rebuild the structural scaffolding of the tissue.
To put some real human context to how powerful this cargo can be, we need to look at a really striking clinical example from our sources.
Oh, the VLS study.
Yes, the study focused on a condition called vulvar lichen sclerosis, or VLS. For anyone unfamiliar, VLS is a chronic inflammatory condition that primarily affects the genital tissue.
It's a really tough condition.
It causes severe thinning of the mucosa, architectural destruction, chronic pain, and an itching sensation that is so intense it can literally completely derail a person's life.
It is a devastating diagnosis, frankly. The structural integrity of the skin essentially breaks down, leading to scarring, tearing, and just a massive loss of quality of life. and it is notoriously stubborn and resistant to a lot of standard treatments.
So researchers in the study took 7 patients with VLS. These were women with a mean age of 56. The doctors administered twice monthly intradermal microinjections of just 3 milliliters of PRP into the affected tissue.
A very small amount.
Right, and the data they recorded after a maximum of 4 sessions is staggering.
The transformation in the data is profound. So the patient's baseline pain score on a 10-point visual analog scale started at a 5.6. By the end of the treatment, that mean score plummeted all the way down to a 1.
Wow. And the pruritus, that severe, life-altering itching, that dropped from an 8 out of 10 down to a 1.
It's incredible.
I mean, imagine living with an 8 out of 10 itch every single day. You can't sleep, you can't walk comfortably, you can't wear certain clothes. Dropping that to a 1 is a total paradigm shift for a patient.
It really is, and we see that paradigm shift reflected in their sexual function scores as well.
Right, the FSFI scores.
Yeah, the researchers utilized the Arabic version of the Female Sexual Function Index. Before the PRP intervention, the mean score across the group was an 8.5, indicating severe dysfunction and pain. Following the PRP sessions, that score more than doubled to 19.3.
That isn't just a minor statistical improvement. That represents a fundamental restoration of tissue elasticity, nerve function, and mucosal health.
Absolutely.
If I'm piecing this together, getting an intimate PRP injection is basically like hiring a highly specialized molecular construction crew. You're bringing them to an old, collapsing building, and they show up with the foreman, the plumber, the architect, and the raw materials to completely rebuild the vascular network and the collagen scaffolding.
That analogy hits the nail on the head. I mean, their sole directive is to build, repair, and fortify.
But this brings us to the central conflict of our deep dive. What happens if that patient is simultaneously taking long-term corticosteroids?
That's where things get messy.
Well, like, let's say they are on a daily dose of prednisone for an autoimmune issue, or they are applying a highly potent topical steroid. I'm guessing the steroid acts like a stop work order on our construction site.
Honestly, calling it a stop work order is almost too gentle.
Oh, really?
Yeah, when we dive into the molecular mechanisms detailed in our sources, it looks far more like a catastrophic cellular shutdown. Steroids are remarkably efficient at doing exactly what they're designed to do, which is suppress the immune system. But the problem is, the regenerative process requires a very specific immune sequence to get started.
Okay, walk me through that. What is the steroid actually doing to the tissue the moment the PRP is injected?
Well, it starts at the very genesis of the healing cascade. When PRP is injected, the physical trauma of the needle and the initial release of the platelets rely on a brief, highly localized inflammatory flare.
A little spark.
Exactly. That acute inflammation is the biological alarm bell that tells the body to mobilize the healing forces. However, corticosteroids function through glucocorticoid receptor-mediated suppression. They specifically target and suppress NF-κB and COX-2.
Wait, KOX2. I recognize that. Isn't that the same enzyme that over-the-counter painkillers like ibuprofen target?
Yes, it is.
So you're saying a heavy systemic steroid is doing the same thing, just on a much more massive scale.
You're hitting on the core mechanism there. While NSAIDs block KOX enzymes to reduce mild pain and swelling, heavy steroids go straight to the master control board.
The NF-κB you mentioned.
Right. NF-κB is essentially the master switch for inflammation inside the cell nucleus. By suppressing it, the steroid ensures that the initial flare never fires. The alarm bell is silenced.
That makes sense.
But the suppression goes much deeper than just hiding the alarm. Steroids actively halt the proliferation of tenocytes and fibroblasts.
And as we established, the fibroblasts are the factory workers that actually manufacture the collagen.
Yes. And clinical research demonstrates that therapeutic concentrations of steroids reduce overall collagen synthesis by a massive 30 to 50%.
Wow. So they are cutting the production line in half.
It gets worse. The factory workers that remain suddenly find that their environment is turning toxic. Corticosteroids significantly increase the expression of matrix metalloproteinases, specifically MMP1 and MMP3.
Matrix metalloproteinase. Our notes describe these as molecular scissors. How exactly do they function?
So they are specialized enzymes designed to cleave and degrade the triple helix structure of existing collagen.
Oh,
Yeah. In a healthy body, you need a small amount of them to clear away dead tissue. But steroids crank the dial way up on these enzymes. So not only has your new collagen production been slashed by 50%, but your tissue is now flooded with enzymes that are aggressively chewing up the healthy collagen you already possess.
that is just brutal. So you're starving the tissue of new building materials while simultaneously dissolving the foundation.
Exactly.
And our sources point out that this destruction isn't limited to just collagen, right? It severely affects hyaluronan as well.
The sources are very clear on that point. Glucocorticoids induce a near-total suppression of hyaluronan synthase mRNA.
And what does that mean in plain English?
Well, hyaluronan, or hyaluronic acid, is the molecule responsible for giving tissue its moisture, its volume, and its structural plumpness. It binds to water.
Right, you see it in skincare all the time.
Exactly. So when you suppress the specific synthase that manufactures it, the tissue quickly becomes dehydrated and frail, leading to severe organ and tissue atrophy. We see a vivid, highly visible example of this in dermatology with a condition known as topical steroid damaged face.
I saw that study in the stack. Patients who overuse potent over-the-counter topical steroids medications like clobetasol or mometasone, they actually develop this severe cutaneous damage.
Yes, it's very distinct.
Their skin becomes paper-thin, transparent, intensely red, and incredibly fragile. It literally breaks down because the matrix has been depleted.
Because the scaffolding and the moisture barrier have been entirely stripped away. But if we want to understand the most insidious effect of steroids on a cellular level, we have to go one layer deeper to the actual signaling pathways.
Okay, let's go deeper.
Corticosteroids physically alter the way your cells communicate with one another.
How do they do that?
Remember TGF-beta1, the master architect we discussed earlier?
Yeah.
In a normal, healthy environment, TGF-beta sends its instructions down a very specific molecular pathway called the TGF-br1-SAP23 axis. Let's think of this as the tissue building track.
Okay, the building track, got it.
When a cell receives a signal on this track, it knows to produce healthy collagen and reinforce the tissue. But glucocorticoids actually hijack the receptors. They shift the TGF-beta signaling away from the building track and force it down an alternate route, the XPRL1-SMAD1 axis.
Let me stop you there because I want to make sure I am picturing this correctly.
Yeah.
It's like the PRP is putting a train on the tracks, full of blueprints and building instructions.
Yes.
But the steroid operates like a malicious switch operator. It pulls the lever, switches the tracks, and sends that train into a totally different facility where the instructions get completely misinterpreted.
That is exactly the dynamic. The PRP is screaming build, but the steroid alters the receiver so the cell processes it as halt. It dampens the entire regenerative process at the receptor level.
Okay, I have to step in here and challenge this whole concept because if I'm listening to this, I'm thinking, wait a minute.
What's the catch?
Yeah, we have steroids slashing collagen synthesis by 50%, actively degrading existing tissue with molecular scissors, silencing the inflammatory alarm bell, and literally hijacking the cellular train tracks. Doesn't that make getting a PRP injection while on steroids completely useless?
It's a fair question.
Are patients just throwing their money into the void if they get an O shot while they're taking a heavy dose of prednisone?
That is the pivotal question of this entire deep dive, and the answer lies in understanding pharmacodynamics and strict clinical guidelines. Timing, in this context, is absolutely everything.
So lay out the rules for us. How do clinicians navigate this?
If you look at the official OSHOT guidelines and similar regenerative protocols, providers draw a very hard line. Patients are explicitly instructed to avoid oral corticosteroids like prednisone, dexamethasone, or hydrocortisone for at least 14 days prior to the procedure and a full 14 days after.
That's a full month-long window where the patient's system has to be completely clear of the drug. Why exactly 14 days? What is biologically happening during that waiting period?
It comes down to how these substances operate over time. One of our key sources summarized it beautifully. Corticosteroids are fast suppressors, while peptides and PRP are slow builders.
Oh, interesting. Fast suppressors versus slow builders.
Right. When you take a systemic steroid, it enters the bloodstream and binds to intracellular receptors rapidly, shutting down the factory almost immediately. PRP, on the other hand, takes weeks to stimulate new blood vessels and lay down mature collagen.
So it's a mismatch in speed.
Exactly. If you have a fast suppressor active in your system, the slow builder never even gets a chance to warm up.
It makes perfect sense. It's like trying to plant a delicate, expensive garden the exact same afternoon.
Yeah.
You soak the entire yard in a heavy industrial weed killer.
Yes.
You can plant the seeds all you want, but they're going to die. You have to wait for the chemicals to wash out of the soil, for the pH to neutralize, before the PRP seeds can actually take root and sprout.
What's fascinating here is that we have animal models that prove just how transient this suppression is, which really validates that 14-day clearance window.
Oh, tell me about the animal models.
Researchers conducted a study where mice were treated with systemic hydrocortisone, and then their wound healing capabilities were assessed. On day 7, the steroid-treated mice displayed a highly significant reduction in scar resistance.
Meaning the tissue was physically weaker?
Yes, the newly forming tissue had much lower tensile strength. It was fragile and prone to tearing because the collagen hadn't matured. The fibroblasts were still suppressed. But here's where the timeline becomes critical.
Okay.
When researchers tested the tissues of those same mice on day 14 and day 21, there was no longer any significant difference in strength between the steroid group and the healthy control group.
Oh, wow. So the vulnerability isn't permanent. As long as you stop taking the drug, the tissue remembers how to heal.
The early phase weakness is severe because the steroid is actively blocking angiogenesis and fibroblast activity. But once the drug's half-life expires and the glucocorticoid receptors are finally freed up, the cells wake up.
They just bounce back.
Exactly. The healing cascade eventually recovers its momentum. Steroids delay the tissue remodeling. They don't permanently delete the body's ability to execute it.
Okay, so that perfectly explains the logic behind the 14-day rule. The steroids halt the process. But if you give the body a 2-week buffer, the receptors reset and the PRP can do its job.
Correct.
But as I was reading through the notes, I noticed a huge glaring paradox here.
Oh, I know what you're going to say.
Yeah. We've established that steroids block PRP if they are taken concurrently. But what happens if someone is dealing with the long-term aftermath of steroids? What if their tissue is already paper-thin, dehydrated, and atrophied from years of chronic use? Can PRP actually be used as a rescue therapy in a depleted environment?
This is the area where regenerative medicine gets truly remarkable, and it forces us to rethink the boundaries of cellular repair. Let's circle back to that vulvar lichen sclerosis study we discussed in the first section.
Right. The study where the patient's pain dropped from a 5.6 to a 1 and their sexual function scores doubled after the microinjections.
Exactly. I intentionally held back a crucial piece of context about those 7 patients.
Oh.
They didn't just have severe treatment-resistant VLS. Every single one of them had been actively using clobetasol propionate, which is a class 1 ultra-potent topical steroid for a mean duration of 4.3 years.
Wait, 4.3 years? They were applying a highly potent steroid directly to mucosal tissue for over 4 years.
Yes. Their tissue was heavily atrophied due to the exact long-term steroid exposure we just analyzed. The collagen matrix was decimated, the hyaluronan was suppressed, and the vascular network was severely compromised.
Wow.
It was, biologically speaking, a highly hostile environment.
But the PRP still worked. I'm having a hard time wrapping my head around this. We just spent 10 minutes talking about how steroids physically switch the tracks and lock up the factory.
Right, it seems contradictory.
Yeah, if the environment is a biological wasteland, how is the PRP managing to bypass the padlock and rebuild the tissue?
You're hitting on the core paradox. It comes down to overwhelming the local cellular environment. The damage was chronic, but when the clinicians introduced the highly concentrated burst of PRP, it delivered such a massive payload of growth factors.
Like the PDGF and the VGF?
Exactly. The PDGF, the VEGF, the TGF-beta. It delivered so much that it essentially outcompeted the lingering suppressive signals. Despite over 4 years of active steroid damage, a maximum of 4 PRP microinjections resulted in documented clinical improvement in genital atrophy and acromia.
Acromia, that's the loss of skin pigmentation, right?
That's right. And at a 6-month follow-up, 6 out of the 7 patients were still in remission.
That is just incredible. The PRP came into a decimated neighborhood and successfully flipped the entire local economy. Are there other studies in our stack backing up this rescue mechanism?
There are, actually. The stack includes a preliminary MDPI study that specifically investigated wound healing that had been purposefully suppressed by corticosteroids in rat models.
And what did they find?
They discovered that applying PRP, often in conjunction with mesenchymal stem cells, had highly positive therapeutic effects. It effectively overrode the steroid-induced suppression and kick-started the healing process all over again.
So what does this all mean for you as a listener? We have steroids acting as the ultimate biological brake pedal, shutting down the healing cascade. But then we have clinicians actively utilizing PRP to repair the very damage caused by that exact brake pedal.
That's quite the irony.
Right. Are steroids the ultimate enemy of PRP, or is PRP the antidote to steroid damage?
Consider what that means clinically. It's a highly dynamic interplay. In fact, in certain specialized areas of dermatology, physicians will intentionally use both therapies at the exact same time to orchestrate a specific outcome.
You gotta be kidding me. After everything we just outlined about how they cancel each other out, doctors are mixing them on purpose.
They are, specifically when treating keloids.
Okay, keloids.
Yeah, a keloid is a severe overgrown scar where the body essentially forgets how to turn off the collagen factory. It just keeps building and building. In these cases, dermatologists will sometimes intentionally combine a PRP treatment with a steroid injection.
Why would they do that?
They use the steroid to act as the stop work order. It puts a hard ceiling on the excessive buildup. And then they use the PRP to ensure that the tissue remodeling is balanced properly between collagen type I and type 3.
That is a wild biological balancing act. You're using the steroid to put a roof on the growth so it doesn't get out of control, and you're using the PRP to build a healthy, stable floor.
It proves that steroids aren't inherently toxic to tissue. They are just incredibly blunt instruments. When they are used chronically, systemically, or at the wrong stage of healing, they destroy the tissue matrix. But when they are timed perfectly or combined carefully with a regenerative powerhouse like PRP, clinicians can literally sculpt the healing process.
Okay, let's bring this all together because we've covered a massive amount of cellular ground today. If you take one actionable thing away from this deep dive, let it be this.
A big takeaway.
Right. Corticosteroids are undeniably effective at stopping inflammation, but they achieve that by hitting the biological pause button on your connective tissue. They silence the inflammatory alarm bell, they shut down the fibroblasts, they halt collagen production by up to 50%, and they unleash molecular scissors that degrade the healthy matrix you already have.
And that biological reality is exactly why clinical protocols are entirely non-negotiable. If you are investing the time and money into a regenerative treatment like an intimate PRP injection, you absolutely must pause systemic steroids for 14 days before and 14 days after the procedure.
The weed killer has to wash out of the soil.
Exactly. You have to wait for the receptors to clear so the growth factors have an unsuppressed environment to do their work.
But on the flip side of that coin, if you are someone who has suffered from severe tissue atrophy due to years of heavy steroid use, the research shows that all hope is not lost.
Definitely not.
PRP is so remarkably potent that it can act as a rescue therapy, overwhelming the damaged system with a flood of growth factors, reversing the atrophy, and rebuilding the tissue from the ground up.
It truly highlights the sheer resilience of human biology when it is finally given the right tools.
It really does. And that leaves us with a highly provocative thought for you to explore on your own. We spent time unpacking how steroids hijack the TGF-beta signal, maliciously shifting it away from the tissue-building SMAD23 track and forcing it over to the destructive SMAD1 track.
The infamous train switch.
Right. We also know that a massive dose of PRP can overwhelm that system and force the tracks back to the building phase. So, could scientists eventually map that exact molecular override to create a completely new type of synthetic drug?
Oh, engineering a drug that mimics that specific bypass would be the holy grail of modern pharmacology.
Imagine a future targeted therapy that provides the incredible, life-saving anti-inflammatory power of a systemic steroid, but is engineered to completely bypass the SMAD1 axis.
That would be amazing.
No more tissue-destroying side effects, no more paper-thin skin or mucosal atrophy, no more mandatory 14-day waiting periods for regenerative treatments, just pure, unadulterated healing without the heavy biological tax.
It's the dream.
It goes right back to what we discussed at the very beginning. We want medicine to be a clean, simple math equation. Right now, mixing heavy steroids and regenerative PRP is like trying to do complex algebra while someone keeps erasing the chalkboard. But as we continue to map these pathways, maybe one day soon, we really can just solve the equation. Thanks for jumping into the weeds with us today, and we'll see you on the next deep dive.